Good morning, everyone, and welcome to Within's Continuing Education webinar series. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to Mariah, one of our senior nurse care team members. Mariah is a registered nurse here who has been working in the field of eating disorders for the past 2 years, and prior to that, spent several years working with medically complex children and adolescents in both the inpatient and outpatient settings. She is a certified pediatric nurse and has been recognized on multiple occasions for demonstrating exceptional, compassionate patient care. She is passionate about the complex dynamics of navigating how underlying medical conditions and medical complications can impact eating disorder treatment and recovery. Mariah works tirelessly to help clients advocate for themselves with healthcare providers. In addition to caring for clients directly, Mariah also oversees a team of nurses here at Within Health and ensures the highest quality of care. Before we start today's presentation, I do have some general information to go over as well in regards to the CEU credits and the CME credits. I will now pass things over to Jamie to go over the CME credits.
Good morning, everyone. Thank you, Ashley. As Ashley mentioned, my name is Jamie Singletary, and I am the Director of Clinical Brand Development here at Within Health. And I just wanted to share for those of you that will be obtaining credit for today's presentation, you will need to log on to your CEGO dashboard to obtain your CEGO credit. And for those of you that are here to obtain a CME credit, I am going to place my email in the chat. And if you can email me directly, I will then send the instructions for you to obtain your CME credit. For your CEGO credit, you'll just need to log on to your dashboard. But if you are looking for CMEs, please email me and I will see to it that you get those instructions. Thank you.
Wonderful. Thank you, Jamie. And again, for that CEU credit, an evaluation will be sent to the email that you used registering for this presentation. Once you complete the evaluation, your CE certificate will be able to be downloaded and printed. And please utilize your CEGO dashboard, as Jamie mentioned, for all things CEU related. Just as a note as well, we will not be providing the slides today. However, the video of the presentation will be available following up the presentation, and that'll be available in the CEGO dashboard as well. You will not get credit for watching just the video. The credit will only be given to those who attend live today. And to access, again, that video, please utilize your CEGO dashboard. If you do experience any technology issues or need to change devices during the presentation, you will receive credit for that. And for any additional questions, concerns regarding the CEU or the CME credit, I will also provide my email in the chat as well as Jamie so we can make sure that the credits work out. And I will also provide CEGO's direct support information in case you need any additional support within your Git dashboard. Other than that, thank you all for joining us today. We're so excited to have Mariah presenting, and I will now pass things over to Mariah.
Thank you so much for that wonderful introduction. Good morning, everybody. My name is Mariah Eichelberger, and I am the Senior Nurse Lead at Within Health. In this role, I care directly for clients and work closely with the outpatient medical providers in providing medical management as they undergo treatment for their eating disorders in the PHP and IOP levels of care. I frequently find myself working with medically complex clients, including a handful of clients with Mast Cell Activation Syndrome diagnoses, and even more with potential Mast Cell Activation Syndrome who do not have an official diagnosis at this time. My expertise on this topic comes from this direct experience working with my clients and their providers, as well as from extensive research on the topic and recent completion of a rigorous Mast Cell Activation Syndrome professional consultation group with Dr. Jennifer Gaudiani, wonderful eating disorder expert physician. Moving forward, I will refer to Mast Cell Activation Syndrome as MCAS or mast cell. Before we jump in today, I want to preface this talk by acknowledging that mast cell is an emerging and very nuanced topic, and there is still a lot of research to be done and questions to be answered. It is thought to be a very common, yet under-recognized chronic disorder. The first case reports of MCAS were only published 15 years ago. Those that consider themselves experts in the field, myself included, are still learning more every single day. There are still many more questions than answers. This presentation will review the pathophysiology, diagnosis, and treatment of the disease, with a particular focus on the considerations for the eating disorder population and the role that non-prescribing members of a client's treatment team can play to support a client when there is suspected MCAS. The objectives today are to list 3 symptoms of a client's presentation that could indicate MCAS, describe at least 1 recommended step to be taken in the presence of suspected MCAS, explain 2 ways that MCAS can serve as a barrier to eating disorder recovery work, and naming at least 2 potential ways you can support a client with suspected mast cell. Unless you're a medical professional, you've probably never heard of mast cells. Mast cells are a type of white blood cell that play a very important role in our immune system, detecting and responding to foreign substances throughout the body. Mast cells are best known for releasing histamine and being a key player in serious allergic reactions, like someone having anaphylaxis from bee stings or peanuts, or an asthma attack that might be triggered by something like smoke. They are present throughout the body, but are more prevalent in environment-facing surfaces, including the GI tract, lungs, genitourinary system, skin, and along blood vessels and nerve endings. When these little cells are activated by a trigger, they have the capacity to stimulate over 1,000 mediators, among them histamine, heparin, and many inflammatory factors. These are chemicals which mediate reactions throughout the body and help protect the body from harm. When mast cells are well behaved, they only release these mediators in specific circumstances, such as anaphylaxis or locally due to a bug bite. A normal mast cell reaction is appreciated, such as a fire truck showing up to a house fire. Mast cell activation syndrome happens when mast cells misbehave and aren't working properly. In individuals with mast cell, there is an inappropriate release of mast cell immune mediators into the body, leading to symptoms across multiple organ systems, which can range from very mild to life-threatening. It is important to recognize that mast cell is not a problem with the overproliferation of mast cells, as seen in conditions that are more commonly recognized, such as mastocytosis, but rather as an excess production of the histamines and mediators by an ordinary number of mast cells. If you see this image here, it shows that when a mast cell becomes activated, it degranulates, other words, explodes, and tiny mast cell granules containing various mediators are released throughout the body and result in multisystemic effects. As you look here, you can see as it's degranulating or becoming activated, exploding, these tiny mediator granules are kind of coming off, and that is spreading throughout the body. There is a large population of humans across the planet who have mast cells that are unstable. They release their contents when they are not supposed to. It is going to be astounding to you how many symptoms can emerge just because of a mast cell that releases its contents when it isn't supposed to. We are not exactly sure how this all comes about. It's thought that there is probably an inheritable element. It is thought that the various things we are exposed to in our world probably coordinate with some genetic predisposition. Beyond that, usually each individual has to have one or more triggering episodes in their lives to bring this into being, including physical and psychological stress, which can include increase in estrogen around puberty, GI illness or a parasite while traveling, mold exposure, and eating disorders can also be a huge one. Research estimates that up to 17% of the population has MCAS, and it shows a strong female predilection. Interestingly, some individuals with mast cell barely have any symptoms at all and never worsen. Others have ultra severe symptoms and end up in inexplicable anaphylactic shock in the hospital weekly, while the majority fall somewhere in between. Each person's presentation, severity, triggers, and treatment are unique. Doctors just in the last 15 years or so began realizing that inappropriate mast cell activation is likely the single issue underlying many patients with large lists of problems of the general themes of inflammation, allergic type issues, and a wide variety of dystrophisms, which mean abnormalities in the growth and development in potentially any tissue in the body. It is estimated that there is an even higher prevalence of mast cell in the eating disorder population. More research is needed to quantify this prevalence. You may ask, why such a high prevalence in the eating disorder population? And this is not entirely known. However, there are a few hypotheses, including worsened gut function, which predisposes individuals to restrict food, as the negative conditioning of eating begins to outweigh the positive experiences most people experience with food and eating, and makes the road back to nutritional rehabilitation much more painful and challenging. A large number of healthcare providers either haven't heard of mast cell or don't believe it exists, despite prediction that it affects such a large proportion of the population. There are a few reasons for this, including providers having a hard time believing something that is so hard to measure by a blood test, vital signs, or a scan, the very broad and non-specific symptoms that can arise, and it being something that providers did not learn about in medical school or in training. We will speak about these various challenges in the coming slides, and it is important to be aware that this is currently a condition that is poorly recognized in the medical community. I would like to introduce a case, which I will reference throughout the remainder of this presentation. Jane is a 40-year-old cisgender Caucasian woman with diagnoses of anxiety, depression, POTS, IBS, and other specified feeding or eating disorder, otherwise known as OSFED, which is presented with restriction, binging, and purging, starting with food group restriction around age 13, when finding that food was making her feel sick. Jane was diagnosed with Mast Cell Activation Syndrome in 2022 after seeing a new primary care provider after decades of suffering from a long list of seemingly unrelated symptoms, which never showed any significant improvement with eating disorder treatment, nor with traditional medical treatments, despite seeing numerous specialists, including allergists, gastroenterologists, dermatologists, rheumatologists, and internal medicine, to name a few. Since Jane was a little girl, she's had stomach aches and experienced nausea after meals, which make it hard for her to eat. She has never had quote-unquote normal digestive system, with chronic severe bloating, alternating constipation and diarrhea, and GERD. In addition, she feels like she's allergic to her period, which each month is accompanied by terrible cramps and mood changes. She has a history of getting random hives on her skin, and on a couple of occasions, she has had severe allergic reactions to unknown triggers, once requiring an ER visit as her throat began to close. Dermatologists and allergists had no idea what was causing these reactions, as her allergy tests have always come back negative. Further, Jane experiences chronic pain, especially in her joints, as well as chronic fatigue. She noticed she constantly has a drippy nose and has noticed she feels severely ill after just a few sips of alcohol, including headache, flushing, nausea, and even acute worsening of depression for several days after drinking. She also experiences significant jumps in her heart rate when she stands up and frequently notices dizziness. It can be hard for her at times to just take a shower or even stand in the kitchen to cook a meal. She was told repeatedly that recovery would fix the symptoms she experienced, and it is all due to her eating disorder. However, she has fully weight restored in treatment many times and has found this not to be the case. While the symptoms felt real, there were times Jane thought maybe she's just overly sensitive. It is not until she received the diagnosis of MCAS and started treatment that she noticed meaningful improvement in all of her symptoms and started making meaningful progress in her eating disorder recovery and in healing her relationship with food. We will talk more about Jane shortly. I could easily spend an hour going one by one through potential symptoms that someone could present with. However, I am not going to do that. What is important to remember is that mast cell symptoms often occur across multiple organ systems, can come and go seemingly randomly, migrate, and vary dramatically in intensity and in presentation. Frequently, symptoms flare in response to triggers, i.e., these major physiological or psychological stressors, which we will discuss shortly. Any one of these symptoms could be related to a wide variety of causes, but a whole bouquet of them across organ systems is highly suggestive of mast cell. I only included a sampling of symptoms on this slide. Some common symptoms I would like to highlight include skin sensitivity, including flushing, itching, rash, redness, and/or hives, feeling feverish with or without an actual elevated temperature, extreme fatigue, pain, especially in the joints, abdomen, bones, or muscles, headache, drippy or stuffy nose, sinus congestion, throat clearing, difficulty breathing, coughing, eye irritation, swelling, especially of the feet, hands, abdomen, or face, worsening of rapid heart rate, lightheadedness and fainting, blood pressure instability, easy bruising and other bleeding problems, painful lymph node swelling, excessive sweating, digestive distress, which frequently worsens after eating, including pain, nausea, bloating, and loose stools, surges in depression or suicidality, mouth sores, brain fog, nerve issues, bipolar 2 like mood disorders, unexplained changes in weight, and painful and heavy menstrual cycles. If too many mediators are released into the system all at once, someone with mast cell can experience anaphylaxis. Every patient with mast cell is going to present differently. Some may only have a few symptoms, while others are going to have many symptoms. Symptoms of mast cell are confoundingly diverse due to the presence of mast cells in every vascularized tissue, and because mast cells produce and release more than 200 mediators, each with a unique array of direct and indirect, local and remote, and acute and chronic effects. Given this vast array of symptoms, these patients are often being treated separately by many different specialists who are puzzled at the patient's real but unmeasurable symptoms and their lack of response to typical care. Frequently, these patients have for years been passed back and forth between providers and been told, it's all in your head, or you're just sensitive. We will speak about this shortly, but such conclusions from powerful and trusted clinicians can be devastating and can deeply undermine patients' sense of themselves, their trust in their bodies, and their ability to believe their own symptoms. As briefly discussed while discussing symptoms, triggers are physiologic or psychological stressors which cause the activation of abnormal mast cells, thus leading to the release of immune mediators and therefore symptoms. These are not the root causes, but rather the conditions that may trigger mast cells to misbehave in someone who is genetically predisposed to mast cell, resulting in symptoms or in worsening of symptoms. Classic mast cell triggers include alcohol of any kind. This can include, what you may think about as alcoholic beverages, as well as alcohol in skin products, other topical products, makeup, mouthwash is another big one. Artificial dyes can be another big trigger. This includes FD&C, red, yellow, and blue. And this can include common products you may think of, such as food, as well as medications, supplements, drinks, and soaps. Jane recently realized, oh, so this is why I get flushed and have stomachache when I eat M&Ms, but I can eat a chocolate bar just fine. Another common trigger is mold. Someone living with mold will never get better, no matter what triggers are avoided or medications are taken because of the stress it's putting on the body. Most clients with mast cell feel worse in the sun and struggle with extreme heat and sun exposure. Jane has found that she feels much better during the cooler times of the year. Scented skin and home products can also serve as a trigger, as well as stress. And this includes emotional and physical stress, and could include anything from final exam week, family conflict, or menstruation to being sick, like with something like COVID or the flu. It is important to note that clients with chronic PTSD and or high anxiety may be particularly susceptible to flares as they're living in a chronic state of escalated stress. Eating disorder behaviors, in and of themselves, restriction of calories, binging, and purging are all major triggers as they are so stressful to the body as well as to the psyche. Finally, specific foods can serve as triggers for certain individuals. While this needs to be handled delicately for someone with an eating disorder, some individuals with mast cell can legitimately react to a broad variety of foods. Jane has found that she is very sensitive to gluten products. When she consumes gluten, she frequently ends up with severe gastrointestinal distress and is glued to the toilet for hours with severe diarrhea. Every client will have their own individual triggers that will vary depending on how active their mast cell is at the time. One of the huge challenges in MCAS is that triggers can change from week to week. Jane has found that something that makes her feel crummy the week of her period may be completely fine for her the week after. She finds that during highly stressful times, her mast cell reacts to more triggers than during times that she's well rested, nourished, hydrated, and feeling supported emotionally. For example, Jane actually has no problem eating M&Ms and can better tolerate gluten when her MCAS is well controlled and she is well rested, nourished, and hydrated. This is an MCAS mini screen, which was created by Dr. Jennifer Gaudiani and is used at the Gaudiani Clinic to determine if a patient who does not currently carry the diagnosis of mast cell should undergo further evaluation and proceed to fill out a more extensive questionnaire to help diagnose mast cell. It consists of 6 questions. Do you feel you have physical reactions to foods, medications, scents, or body products? When you drink alcohol, or used alcohol-based products like hand sanitizer, do you get flushed, itchy, have abdominal pain or distress, worsen mood, joint pains, or feel flu-like? Do you often get rashes, hives, or itchy skin? Do you feel unwell, swollen, rashy, itchy, or fatigued after spending time in the heat or sun? Do you experience pain regularly, especially joint, digestive, head, or muscle pain? And do you feel chronically or frequently unexpectedly fatigued? If a client answers yes to 3 or more of these questions, it would be considered a positive screening test and further evaluation for MCAS would be warranted. Jane answered yes to all 6 of these questions. This screening, along with several other extremely useful tools, including a more in-depth questionnaire, can be found in the resources section of the Gaudiani Clinic website. I want to highlight that this is not a validated tool for making a definitive clinical diagnosis. There's no standardized set of screening questions for mast cell at this time, although there is a validated tool created by physician Dr. Molderings in Germany that is used productively in academic studies and at times in clinical practice, called the Mast Cell Mediator Release Syndrome Questionnaire. This questionnaire consists of 57 questions, so it's not quite as easy as this screening to use. Work is being done on developing a validated, standardized screening tool and patient assessment tool that can be used in clinical settings. There are 2 schools of thought among diagnosticians who treat mast cell. First, we have consensus 1 criteria, which require patients to display specific, severe, and recurrent allergy or anaphylaxis symptoms, an elevated tryptase level on a serum sample within 4 hours of a mast cell flare-up, and symptom response to mediator suppressors or mast cell stabilizers. The consensus 1 approach is more aligned with the academic realm, and in my personal opinion, can be quite problematic due to the limited set of symptoms that may not capture everyone, and due to testing being widely inaccessible and prohibitively expensive, as well as a very high likelihood of falsely negative test results, as these labs are very difficult to properly draw and handle. The consensus one approach is estimated to miss 85% of persons who actually have mast cell activation syndrome. On the other hand, the consensus 2 model offers an alternative diagnostic framework, which is much more inclusive and recognizes the complexities of this disease. As you can probably tell, I prefer this model, and this model is endorsed by a much larger group of physicians across medical specialties. Patients meet consensus 2 criteria if they have a unique constellation of symptoms that could arise from pathologically increased mast cell activity in 5 or more organ systems, and their symptoms respond to any treatment targeted at mast cells or their mediators. It is, of course, important to rule out other diagnoses that may account for the full range of symptoms that a client may be experiencing prior to landing at an MCAS diagnosis. This model does not ignore laboratory testing, and lab testing can and should be taken into consideration if able. However, a lack of positive lab testing would not exclude a client from starting treatment, and if they respond to treatment, it seems reasonable to assume some sort of mast cell issue is being managed. The consensus 2 model in essence says that anyone with a reasonable number of symptoms can be empirically started on mast cell activation syndrome treatment, and if they feel better, they have a mast cell issue. It is important as providers to understand that most patients with mast cell dysfunction in primary care will have normal lab tests. I recommend specifically preparing patients for this set of expectations if testing is ordered. Patients with normal MCAS labs still may respond to mast cell targeted treatments. Understandably, there may be concern regarding the potential overdiagnosis by consensus 2 criteria. However, underdiagnosis by consensus 1 criteria seems to be the far larger problem, given increasing appreciation of mast cells prevalence and that most mast cell patients, regardless of illness duration prior to diagnosis, can eventually identify treatment yielding sustained improvement. Of course, it is important to rule out other potential diagnoses when evaluating a client for potential MCAS, and differential diagnoses should be thoroughly explored prior to landing on a mast cell diagnosis. The goal with treatment of mast cell activation syndrome is reduction of symptoms and improved quality of life. MCAS is not curable, and it is important for providers to set realistic expectations for treatment. That said, significant improvement in symptoms and quality of life is possible. It can be helpful to think of the bucket analogy, which is used frequently in discussion around chronic illnesses. This analogy compares the body to a bucket. There's always going to be some water, i.e., our mast cell symptoms, in the bucket, i.e., the human body. Every trigger someone with mast cell encounters is a drop of water falling into the bucket, raising the water level little by little. Once water begins sloshing over overflowing is when symptoms occur. The goal is to keep water from overflowing, and avoiding triggers can play a huge role in this. As mentioned earlier, everyone will have their own individual triggers that will vary depending on how active their MCAS is at the time. And the first step to trigger avoidance is identifying these triggers. Some triggers are going to be easier to avoid than others. For Jane, she reduced exposure to heat by planning indoor activities on hot days. And when she does need to go outside, she brings a misting fan with her to help keep her cool. She also realized that while it felt good in the moment on her joint pain to spend time in the hot tub each night, she consistently broke out in hives and felt ill and dizzy afterwards, so she stopped using the hot tub. She had stopped drinking alcohol years ago, since it made her feel so ill, and she continues to live a sober lifestyle. Jane has had her house inspected for mold and had mold remediation done. She switched to scent and dye-free skin products and laundry detergents. She also has done her best to remove artificial dyes from her life. She switched from drinking Gatorade to a dye-free alternative. Of note, LMNT or Element is a great alternative that is higher in sodium and can actually do wonders for rehydration and does not have any artificial dyes. Jane also seeks out white-colored medications without dyes, which has proven to be tricky, and her local pharmacist has been really helpful in this process. She continues to work with her eating disorder treatment team to work towards eating disorder recovery and to ensure she is nourishing her body properly. She does her best to mitigate stress, and she also recognizes that she cannot avoid stress altogether, and she has begun anticipating that she will feel worse when stressed. Finally, when Jane was first diagnosed, she identified gluten to be a trigger, which caused severe symptoms that impacted her ability to function and to nourish herself. So she began utilizing gluten-free option. Now that Jane's mast cell is being treated and is better controlled, she has actually been able to incorporate gluten back into her diet again. And she knows that when she's in a flare, it may again become an issue. Clients will need to be patient and show themselves, their treatment teams, and their loved ones grace as they start paying attention to what makes their MCAS react and under what circumstances. Some clients can clearly tolerate one of these triggers just fine, in which case they should listen to their body. The goal here is always going to be least restrictive living. In addition to trigger avoidance, medications can be a helpful tool for stabilizing mast cells and for blocking and mitigating the effects of released mediators. Finding a medication regimen that works is a process of trial and error to find what the client responds to. And this can be really, really frustrating and stressful. It can get worse before it gets better. Treatment involves many possible options and depends on the patient response. It took Jane several months to find a medication regimen that worked and significantly improved her symptoms. Generally, clients will start with over-the-counter histamine blockers, which assist in blocking the effects of histamine, which is one of the primary mediators which is released by these misbehaving mast cells and can trigger a cascade of inflammatory responses. These include H1 blockers, which are non-sedating anti-allergy medications such as Allegra and Claritin, and include H2 blockers, which are reflux medications such as Pepcid. Typically, MCAS dosing is higher than the standard dose, but clients can start with a standard dose and go from there. In addition to H1 and H2 blockers, adding in mast cell stabilizers such as quercetin and prescription cromolyn can be helpful for systemic symptom management, specifically for digestive symptoms and skin manifestations. Additional medications may be indicated as well, including additional mast cell stabilizers, low-dose naltrexone, montelukast, benzodiazepines, Xolair, and others. I'm not going to go into a lot of detail on pharmacological treatment, as I do recognize that my primary audience here is not prescribers. However, if you're curious to learn more on this topic, there is a growing bank of literature. I want to highlight that many of the treatments for MCAS are over-the-counter and have very low risk profiles. So non-medical providers who feels this applies to their patients can urge the patient to bring it to their PCP. And if their primary care provider is resistant, or they don't have a primary care provider and are working on getting more comprehensive care, clients can be empowered to educate themselves using reputable resources and to consider if they want to try initial treatments independently in the meantime. Further, it is important to know that medications may need to be adjusted during a flare, as clients may require higher doses and potentially additional medications to control symptoms. Clients often present with a myriad of complex coexisting diagnoses. The interrelationship is unclear. However, there is speculation about whether dysregulated mast cell responses and the recurrence of the chronic release of mediators may be a pathological mechanism underlying many of these conditions. MCAS seems prevalent and may underlie much chronic inflammatory disease. POTS and hypermobile EDS or Ehlers-Danlos syndrome are so commonly seen along with MCAS that they are actually referred to in combination as a triad, which suggests some common mechanisms and potential for significant overlap in the conditions and symptoms. Studies are currently underway to further assess the relationship between these clinical entities. There is a hypothesis that many cases of POTS are likely fueled by uncontrolled mast cell, which suggests that chronic inflammatory mediators of the central nervous system cause activation in a way that leads to POTS. It is actually thought that up to 40% of those with POTS have mast cell, and treating the mast cell will help with the management of POTS. In addition to POTS and EDS, other conditions are also seen to commonly co-occur with mast cell, including small intestinal bacterial overgrowth, which you may have heard referred to as SIBO, superior mesenteric artery syndrome, irritable bowel syndrome, eosinophilic esophagitis, and median arcuate ligament syndrome. Not much is known regarding the relationship between these conditions. However, it is thought that if you can reduce inflammation and stressors across the board, their co-occurring conditions and mast cell will both improve. This has definitely been the case for Jane, who has noticed significant improvement in both her POTS and IBS symptoms since starting treatment for her mast cell. There are many considerations to be taken into account when a client has an eating disorder and also a potential MCAS diagnosis. And it is important to recognize the relationship between the eating disorder and the mast cell. Due to reactions to foods and unpleasant and scary symptoms, MCAS frequently results in negative conditioning too and very complicated relationships with food and feeding oneself, which understandably can contribute to the development and to the continuation of an eating disorder. Food can become terrifying, so no wonder so many people with mast cell have eating disorders, especially ARFID, which frequently gets misdiagnosed as anorexia. It is important to consider that for some patients, eating disorder symptoms may serve as a coping mechanism for their mast cell. In addition, the physiological stress of malnutrition is enormous and can actually drive the mast cell. Therefore, treatment of the eating disorder is key for management of MCAS, and the treatment of MCAS is essential for eating disorder recovery. It is important for clients' eating disorder recovery that their eating disorder providers take into account the complex nature of MCAS during treatment due to the many ways in which their underlying medical disorder has likely contributed to and maintained their eating disorder. We must recognize that these clients have likely experienced gaslighting by doctors when they couldn't find a cause for their physical symptoms, which may have led them to undermine their sense of self and distrust their own bodies, which in and of itself can fuel an eating disorder. We will speak shortly about how we as providers can help clients to regain a sense of trust in their bodies and to advocate for themselves in a healthy way. One final point to make here is the importance of recognizing that untreated MCAS can drive weight gain. The mechanism of this is unknown, although is likely inflammation driven. This can obviously be very triggering for someone struggling with an eating disorder, and it is important for eating disorder providers to be aware of this potential so that we can better support our clients who may be experiencing this. They might not even know themselves that mast cell could be causing it. Let's talk a bit about nutritional considerations. Essentially, someone with MCAS may react to a huge number of foods when they are in a flare. When flared, MCAS can cause legitimate reactions to many foods. And this is not necessarily their eating disorder talking. and it will not simply get better with eating disorder recovery, although eating disorder recovery greatly reduces stress on the body and helps MCAS overall. It can be extremely tricky for a dietitian to manage an eating disorder and MCAS together. However, it is possible, and it is also so important for these patients. What I'm about to say may be controversial and is important to consider. We must believe our patients when they say that certain foods make them feel badly. Encourage patients to tune into their bodies, which we know is not an easy task, and help them to differentiate eating disorder fears from physical mast cell reactions. Where there are lots of times that a patient's eating disorder may impact food choices and get in the way of them nourishing their body adequately, there are also times that these are real symptoms clients are feeling. There can be space for both the eating disorder and for there being an underlying GI issue, be it mast cell or some other condition. Treatment providers and programs need to be open to real food intolerances while also holding firm that caloric inadequacy is never okay. The goal should be the least restrictive eating tolerated. Interestingly, freshly cooked food from fresh sources will be more tolerable typically than leftovers. Most MCAS patients learn to freeze fresh foods and thaw, cook, and eat them the same day. It's a good tip that keeps food options broader. Many MCAS blogs and non-ED informed mast cell providers may recommend restrictive diets, including elimination, low histamine, or low FODMAP diets. However, this is not an evidence-based intervention. There really is no such thing as a low histamine diet, as all foods can potentially trigger histamine, and we recognize that prescribing restrictive eating is dangerous for those with eating disorders. While intermittent fasting, cleanses, and other restrictive diets may truly feel good to patients in the short term, they are not helping them in the long term, as malnourishment increases stress and reactivity. As clients begin nutritional rehabilitation for their eating disorder, they will need to start with focusing on the foods that can be consistently tolerated without mast cell reactivity, and then they can increase intake of those foods until they are consuming enough to meet their daily needs. As their MCAS settles, then they can work on tolerating a broader array of foods. Elemental shakes that are neutral for the gut may, in extreme cases, need to be incorporated early on in the process to help clients meet their energy needs until more foods can be tolerated. You may ask, what is the best way to tease apart an eating disorder from mast cell, and how do I evaluate and navigate these potential food intolerances? That is a great question, and there is no one answer. Every individual is going to be different, and it is sticky. However, some general tips and strategies I have used in my practice include asking questions about what foods seem to make their body feel unwell. What happens when they ingest certain food? Is it followed by an allergic-like reaction or intense physical symptoms, such as Jane's intense diarrhea? Or are symptoms more mild and potentially anxiety-related, such as mild cramping or mild nausea? It is also important to explore how triggering temporarily cutting out a trigger food will be for a client. It's going to always be a risk-benefit analysis. Another tip is encouraging patience with themselves and with their providers as they work to identify potential food intolerances. This does not happen overnight. And having straightforward and honest conversations with clients about what is a true intolerance versus a fear food can be so powerful. It is important to always approach clients with curiosity instead of suspicion, as suspicion is shaming and unhelpful. We have to remember that clients truly know their bodies best. Also, for clients with identified food intolerances, we can explore and ask clients how they can still meet their nutritional needs, challenge their eating disorder, increase variety, and incorporate yummy foods in their diets. When I was working with Jane, gluten was a trigger, so we worked on expanding variety in her diet and challenging food rules by having her go to a local gluten-free bakery and purchase baked goods there, as well as exploring other yummy gluten-free foods. Finally, I also recommend working closely with clients' medical providers and the rest of the treatment team to determine appropriate times when MCAS is well controlled to safely challenge foods which may have previously warranted a reaction. There is likely to be a lot of anxiety and fear about reintroducing a food which previously caused a reaction, so it can be helpful to provide space for processing before and afterwards. There is plenty that non-medical providers can do to support clients who may be dealing with mast cell or a potential mast cell diagnosis. First, MCAS can be recognized by any provider. While obviously we want to be mindful of scope of practice, and a therapist, dietitian, or nurse is not going to be giving a client a mast cell activation syndrome diagnosis. If a therapist, dietitian, nurse, or any other member of a client's treatment team starts suspecting mast cell, they can and should encourage the client to start educating themselves and to discuss this with their medical providers. Of note, when encouraging clients to begin educating themselves, we need to be mindful of the dangers of Dr. Google and the plethora of orthorexic and non-creditable information out there on mast cell. And I would advise steering clients in a direction of reputable resources, which can include Dr. Gaudiani's 4-part blog post on mast cell and eating disorders, as well as other resources listed in the reference section of this presentation. These resources can serve as helpful references for medical providers as well, who may not be very familiar with mast cell activation syndrome. In addition, as we have discussed, MCAS adds another layer of challenge when supporting someone with an eating disorder. It can be extremely powerful for clients to receive validation around the challenges and around the symptoms they are experiencing, and to have someone sit with them through their distress. As mentioned earlier, those with eating disorders and mast cell activation syndrome tend to have a tendency to doubt their own lived experience and symptoms due to prior gaslighting. Taking clients at their word, listening to their lived experience, and letting them make decisions regarding their care is so incredibly important in repairing trauma pathways and in reestablishing trust with their own body. In doing this, we can also empower clients to better advocate for themselves. Furthermore, most medical providers are not eating disorder informed and likely do not recognize or take into account the complexities of managing a chronic illness like mast cell activation syndrome while a person is also struggling with an eating disorder. Medical providers may be quick to recommend restrictive or elimination diets, which can be extremely dangerous for someone with an eating disorder. Eating disorder clinicians of any specialty can assist by collaborating with their clients' medical providers, providing education to medical providers on a client's eating disorder, and discussing considerations for their care and advocating for least restrictive living possible. Finally, clinicians can help support clients in coping with chronic illness and in separating this from their eating disorder, so to improve their relationship with their body. They will likely need frequent reminders that eating is not the problem. And we can support clients in living in self-knowledge, grace, compassion, and gentleness. There is so much more research to be done on this incredibly important and nuanced condition to help further understanding and recognition in the medical and psychiatric communities, and to help countless humans who may be suffering. These conversations around mast cell activation syndrome are so important for increasing awareness and bringing more resources to the research on this topic. I encourage you all to support further research and keep having these conversations. Thank you all for your time today, and I welcome any questions.
Thank you so much, Mariah. That was such a wonderful presentation. I know I enjoyed it, and I'm sure the entire crowd did as well. We did have some questions roll through, and if there are any additional questions, feel free to put those in the Q&A section. You can also put them in the chat. We will try to answer as many as we possibly can. If not as well, I will also put Mariah's email below towards the end of the questions, just in case there's any others that need to connect with her or just have a general question. So the first question that we had roll through was, when would someone consider MCAS cell an eating disorder treatment?
Yeah, and that's a great question. There's no one answer. I think generally for me, I start to consider it, especially for my chronic clients who have been in and out of treatment for a long time. They've done treatment. They've weight restored maybe multiple times, and they've been told that their symptoms are going to improve or going to resolve with eating disorder recovery, but they continue to experience this broad range of symptoms across organ systems that really serve as a barrier for them to be able to truly achieve recovery. And it's then that I start to think, is there something else going on here? And start to kind of look at what other potential things could be happening. And mast cell is one of those things that I start to think about, especially for my clients where it's like, okay, they have IBS, they have POTS, but traditional treatments are not working. What is going on? And that's really when I start to think about mast cell.
Wonderful, thank you. A couple more questions that came in. How do you manage explaining to a patient MCAS ED and recovery?
Yeah, it's not easy. I like to tell clients that we're going to be on a journey together and it's not going to be linear, and we're going to kind of walk this path together, and it's going to be frustrating. It's different for every patient, and we'll work together to figure out what works for them and how we can help to manage their mast cell while also figuring out how to maintain or work towards recovery at the same time, which can be really complex when we're talking about potential food intolerances or sensitivities. And we can figure out how that will look for each patient. So I think really just reminding that patient that we're in it together and we're going to walk this path and I'm here to support them.
Beautiful, thank you. Do we know if there's any research yet about the relationship between MCAS and OCD symptoms, whether as a cause or an effect?
That's a great question. And I have to look back in my literature to like get you that specific information, but I definitely have seen some things about connections between OCD and eating and mast cell. It's thought that a lot of the neurological effects that come from mast cell activation syndrome are related to neuroinflammation that's happening in response um, to these overreactive mast cells. And that can result in a broad range of symptoms, including depression, increased suicidality, mood disorders. And I have seen some stuff on OCD. So I'll have to look at my research to see if I can find any specific statistics, but I definitely think it's a possibility.
Beautiful, thank you. Another question that rolled through was how can I advise clients with busy schedules to prepare food ahead of time without having histamine-rich leftovers? Does freezing pre-cooked foods increase histamine content as well?
I honestly don't know. Um, I'm gonna have to look that one up. I think overall, like putting things in the freezer and not letting them sit out for long periods of time, not letting them sit on the counter, even in the refrigerator. So I would think that freezing a food, even if it's cooked immediately and you're planning to eat it for leftovers, would be better than just storing it in the refrigerator. In terms of how can you get your client to prepare meals ahead of time, I think that's a great big question that a lot of us struggle with in eating disorder treatment. And I think that's something that you can definitely support them around as a provider is like, taking time to prepare and maybe freeze items. I think frozen foods can be good options for people with mast cell. One of my clients that's struggling with mast cell, she's fine with frozen foods. She can do a frozen, microwavable meal. Um, and that works just fine. So it's really figuring out what works for them. Because it is going to be different for every person and every client.
Beautiful, thank you. We had some more questions roll in, so thank you, Mariah, for answering everything for us. Is a general doctor the best place to start to diagnose MCAS or a specific type of doctor, or would you more recommend going to holistic practitioners?
Yeah. It's gonna dep I would say generally the best place to start is gonna be going to a general primary care provider or practitioner, and even bringing that's why I really encourage clients to educate themselves before going in, because unfortunately, a lot of medical providers aren't familiar with mast cell. In a perfect world, clients would be able to go into a clinic that's mast cell that knows what's going on with mast cell and be able to provide that care to them, and that's just not the world we live in, and a lot of times clients with mast cell are going to have to be managed as best as possible with their primary care providers who may be learning alongside with them and maybe can rely on consulting with potentially remote experts who specialize in this field. At times, allergists can be really helpful. And that said, caveat is that allergists tend to go towards that consensus one criteria that we were talking about, that very specific, there has to be this specific lab work, there have to be this specific allergy symptoms, whereas we know that mast cell can present in such a diverse manner. And so sometimes people who go to an allergist who have potential mast cell may become invalidated, where they're saying, well, no, you're not testing this certain way, or you're not having this specific symptom, so I don't think that's it. And then again, they get kind of sent back and don't know where to go from there. So I think it's so hard. And I would say to educate themselves, it's advocate for themselves, go to their primary care provider. And if they're not getting answers, to go to other providers, and potentially even look if there's providers in your area who specialize in mast cell, hypermobility, POTS, all of those kinds of specialties tend to go together. Unfortunately, it does tend to be a lack of those providers, and struggle with insurance coverage. And hopefully that'll be changing. In terms of naturopathic providers, I tend to veer away from those, because I do tend they tend to go towards those really orthorexic tendencies and say, oh, okay, everything is going to be cured if you cut out gluten and dairy and go on a low FODMAP diet. So I think it's really dependent on the provider themselves. If they have some eating disorder knowledge, they can be a great source, but most don't.
Thank you. Thank you so much for that answer too. That was wonderful. A couple more questions as we kind of wrap up our presentation. Again, thank you, Mariah, for being so flexible and answering so many great questions that rolled through. Somebody was interested how Within's team is able to support adults with MCAS, or how you've seen support within the Within Health system.
Yeah. Well, I personally have worked with many clients with mast cell. We generally work really closely with their outpatient medical providers to ensure we're meeting their needs as best as possible, and to, make sure we're kind of covering all of the bases. I, frequently am communicating with their medical providers and saying, hey, I'm seeing a lot of reactivity here. I'm noticing these trends, since I see them so much more frequently a lot of times than their medical providers. So I can provide that information back. In terms of like food intolerances, we definitely do honor those food intolerances. We try to challenge, and it's hard sometimes to tease out what's the eating disorder and what's the mast cell. So we try to do our best to kind of determine, is this something that's coming from the eating disorder, or is this a true food intolerance? And that can be really tricky. So like I said, like for clients before who have true food intolerances, we worked on figuring out other ways we can challenge their eating disorder. Because if somebody is having a true food intolerance and we're forcing them to eat that food, let's say it's gluten, going back to Jane, let's say we're, saying, okay, well, that's your eating disorder talking, you need to eat gluten. And then every time she eats gluten, she's glued to the toilet for the rest of the day with horrible diarrhea. That's not helping her renourish herself. She's losing a lot of nutrients that way. She's becoming incredibly dehydrated, and she ends up in the emergency room. That is not helping her in her eating disorder recovery. So we find that, focusing on the foods that a client can tolerate while slowly trying to expand that window. And maybe it looks like for different clients, maybe it's expanding to other foods that are still within some of those limitations that they can tolerate. And for other clients, maybe they're getting to a point where their mast cell is better controlled, and I'm able to talk with their medical providers, and we're able to practice and provide support around integrating foods that may have previously been a trigger.
Wonderful. Thank you, Mariah. And again, I just want to extend such a big thank you to Mariah for such an incredible presentation, and for being so responsive and really supporting our questions that we're rolling through. And I also want to thank all of you for joining us today and for sharing this space with us. I also provided Mariah's contact if anybody also wants to connect with her. That's in the chat as well. Again, I just want to thank you all for joining us today, and for just being so open in this space, and for asking such wonderful, insightful questions, and showing so much love for Mariah and her presentation. Through the rest of this month, our staff will also be out in the community presenting. Our very own Rebecca Brum will be presenting for the Alliance Group on April 26th, and that is at 11 a.m. Eastern Time. She will be presenting on facilitating corrective emotional experiences in eating disorder care. All of the registration for that information can be found on the Alliance website. So if you want to see our staff out in the community speaking at wonderful events, please check them out. We will also be posting more on our social media sites as our webinar series continues to grow throughout the year. We know we have some really great presentations lined up, so please stay tuned on our social media sites for all of those wonderful registrations to be popping through. Again, thank you all for everything today. If you need any additional support, please reach out to Jamie or myself for your CEU or CME credits. Other than that, thank you so much, Mariah, again, and thank you all for joining us today. Have a wonderful day, everyone.